My name is Anne Russell. I'm from the Russell Family Fetal Alcohol Disorders Association, and I'm here today with Dr Tigg, who is a paediatrician from Cairns with a very strong interest in fetal alcohol spectrum disorder. Good morning, Dr Tigg.
Hi Anne, and thanks very much for asking me to be a part of this today.
It's my pleasure. I'm very grateful that you had the time. So I've got a few questions for you. Do you find that ASD, autism spectrum disorder, is often misdiagnosed for fetal alcohol spectrum disorder?
I think that's a really good question. That comes to the fundamentals, I think, of how we diagnose autism spectrum disorder, which is certainly not just one thing. Increasingly, we are finding causes for the clinical picture that we call ASD. And certainly exposure to alcohol in utero can cause damage to the brain, which gives children a neurobiology which presents in the same way as autism spectrum disorder at times. What I think we should all be doing, and what I love about the way that the Australian guidelines have been written, is that they don't look at just one aspect of the brain for fetal alcohol spectrum disorder. They look at all of those 10 brain domains. And I think for every single child that we're looking at in this space, we should be looking at all of those 10 brain domains rather than just one. And I think that will lead us on as clinicians to take better histories. And one of the things I think that my clinical colleagues struggle with is talking about alcohol exposure in utero. It's difficult to bring up if you make it difficult to bring up, but it doesn't have to be. And so I think part of the essence of really understanding these children is being able to have those conversations in your clinical room about alcohol in the same way that you would have a conversation about anything else. And so for me, it's really important when I take a history, and when you come into my clinic, whoever you are, I will ask you about your pregnancy. When did you become pregnant? Were you planning to become pregnant? How many cigarettes did you smoke? How much marijuana did you smoke? How much alcohol did you drink? It's just a normal part of history taking. Does that answer your question?
Absolutely does. And I agree that it should be part of every clinician's procedure to talk about alcohol use in pregnancy. It's not the difficult conversation that people think. It can just be one of many, like you said. So, yeah.
And I think the important thing to remember as well is that 80% of women of childbearing age drink alcohol in Australia. You know, we are a drinking culture. And 50% of pregnancies are unplanned.
That's right.
So at least 40% of pregnancies are going to be at risk of alcohol exposure in utero. So it's not something that just occurs in isolated populations. It occurs across the socioeconomic spectrum in all cultures, races, well, not all cultures probably, but all races. It's very non-discriminatory.
It is. Thank you very much. So the second question is, what documentation do parents require if they were to come to you for a diagnosis, if they suspected FASD? What would you want them to have?
You don't have to have any documentation if you don't have any. But if you do have things, then what I would like is anything that you have in the way of assessment of the 10 brain domains. So I won't go through the 10 brain domains today. You know what they are, and they're on the FASD hub diagnosis guidelines. But for example, if the child has already seen a psychologist or a guidance officer and had an assessment undertaken, bring that with you. If they've seen a speech language therapist, bring that report with you as well. But don't feel that you have to go out and get all of those things done before you come to see me, because whilst I think in terms of managing these children, understanding all 10 of the brain domains is really important because they interact. To make a diagnosis, you actually only need to demonstrate significant deficit in 3 areas, as well as having a known or assumed alcohol exposure in utero.
Would parents have to have evidence of prenatal alcohol exposure?
You don't have to have evidence of prenatal alcohol exposure, but if a mum were to come to me, the biological mother of the child, and that mum said, I absolutely did not touch 1 drop of alcohol in pregnancy, then obviously I would not be able to make that diagnosis. But if we are not sure, then that doesn't preclude a diagnosis of fetal alcohol spectrum disorder if there is reasonable suspicion.
Okay. And moving forward, I guess, what sort of medications are the most suitable for a child with FASD? Is there anything that can mitigate some of the symptoms of the condition?
It's really timely that you ask me that question at the moment, because there's a lot of discussion in the medical literature at the moment around appropriate medications for children with FASD. And we don't know at the moment exactly which medications are the best. I have some experience in terms of some of the medications that I feel work quite well in the majority of children. But I think what we have to remember is every child is different, and so medications work differently for different children. We also have to be really mindful of the etiology of FASD. So we know that the exposure causes brain damage. It causes the brain to grow in a different way. And that varies according to at which stage of pregnancy the baby is exposed to alcohol. As a result, you may find that certain parts of the brain don't have as many nerves as they might if the child had not been exposed. And depending on which neurotransmitters those nerves use to talk to one another, different medications may be useful. So there isn't a one-size-fits-all, and there's only really 2 brain domains that medications are useful in, and that's in the brain domain of attention and mood regulation.
Can I ask you another question about medication?
Of course.
Do you often find that your children will respond in a different way to medication? For example, if something's meant to sedate, that it amps them up. Is that something that you find?
I find that children can have what we call an idiopathic reaction to medication, whatever their brain neurobiology is. But I think the difference, for example, if we look at attention, the difference between a child who has ADHD, has a strong family of ADHD, and has no other neurodevelopmental differences, compared to a child who has attention issues that present exactly the same way as ADHD, but multiple complexities in their neurobiology, they don't respond in the same way. And so sometimes it's important, and I say this all the time to people, but you just have to look at that individual child, because if that individual child has a difficulty in one area and then you medicate for a different area, then you've got to understand how that's going to impact upon the area that you're not medicating for. And I think that's why we sometimes see reactions to medications that we're not expecting.
And just one more question. I find with many parents, they are given medication for ADHD, which works for a short period of time and then seems to stop working. Is that something that you find as well, or is that?
Well, I think what we have to remember as well is, although these children's brains are different, they're still developing. And so any child might stop having as good a response to medication as their brain continues to grow. So between the age of 0 and 12, we're making lots and lots of connections. Every time we're exposed to a different thing, we make another connection in our brain. And then between 12 and 24, we're pruning those connections back and keeping the ones that we reinforce. And so that's all changing at the same time as we're giving these children medications to change the transmission between the nerves. So yes, any child can have a difference in the way that they respond. And we certainly, if you just take ADHD, pure ADHD, you'll find that as young people go through puberty, when they're doing that pruning, they might need more medication. And then when they go into adulthood, because they've got a more organised brain, they need less.
Oh, right. Okay, that's very interesting. Thank you. I didn't realise that. I've had a number of people say that, and I thought the difference may be that the child actually has FASD and ADHD or not, or just has FASD. So yes, thank you for clarifying that. So moving forward again, how would you manage the behaviour of a child, a teenager or a child with FASD who's starting to get into alcohol or drugs or both?
That is a really, really good question, and there isn't, again, a one-size-fits-all answer to that. If that was the first presentation to me of the child, that would be extremely difficult, because I don't think you can manage any child until you fully understand them. And we need to understand why they might be accessing recreational drugs or alcohol. So for some people, it's because they don't have the ability to understand the social interactions, and so they're very easily led down that path by their peers. Mm-hmm. For other people, it's because they are struggling with attention and they have somehow had exposure to maybe marijuana and realize that they can concentrate more. Or it might be that they have anxiety and they've realized that the marijuana can help them. So it's really about delving down into what's actually going on for that person. Why are they accessing these things? And that can take a really long time, because a lot of these young people don't have the ability to express themselves in a way that we might be able to recognize and hear from them. And so we've got to get to know who they are, what their brain is like, and then we can work forward with them. And that takes a lot of time. Mm. So I don't have an answer for you. And of course the other thing is that all teenagers will be exposed to people offering them these things, and all teenagers have a tendency to rebel against authority and their parents. And so you have to be really mindful of coming in and being really dogmatic and really prescriptive, and saying to them, you just can't do that. You've really got to get into their head and understand them. And again, when I interview young people, often without their parents, but not always, I won't say to them, do you smoke marijuana? I will say, how much marijuana do you smoke? And they'll say, not much. And then I'll say, so how much is not much for you? And then you find out they're actually smoking quite a lot of it. So it's about, again, the same as going back to the alcohol exposure in utero, it's about destigmatizing it for them, accepting that, okay, well, this is something that young people will do. Let's talk about it. Let's have an open conversation without you feeling as though I am just telling you what to do. Mm. The other thing I think to say in that space is that if you do use marijuana and alcohol, any medications that might be effective for attention will be much less effective. So that's another conversation. So if the child has a cognitive capacity, I would be doing what we call motivational interviewing, which is talking to them about the risks, being respectful of them as an adult, and saying to them, you need the information to make the decision, because they want to make their own decisions. They want to be independent. And if you give them that power, then hopefully, with the right information over a period of time, they'll make the right choice.
In terms of parenting children with FASD, by the time we get them to that stage, we often know that they can't make the right decisions because the part of their brain that they need to make those decisions and see the consequences is not working in the same way.
I agree, and I'm glad that you brought that up, because many children don't have the capacity, despite medications and appropriate psychological intervention, they don't have the capacity to live in an unscaffolded manner. And our colleague Doug Shelton speaks to this, and he says that these children need an external brain. And then it comes down to, okay, so we empower the people who are going to be that child's external brain, whoever they might be, to understand them completely, and to have the capacity to keep them safe. And this is where the NDIS can be really helpful, because trying to do that on your own as a parent is soul-destroyingly difficult. And if we can put the right structures and supports around a child so that there is more than one person there as their scaffold, then we have a much greater chance of success.
Dr. Tigg, thank you so much for your time. I really appreciate it, and I'm sure that people who see this video will really appreciate your insights. I hope we can do this again. Thank you very much.
Thank you, and I'd love to do this again with you.
Fantastic.